obviously women's health is a very, very broad subject. We're going to focus on 3 main areas. And we're going to start off by looking at preconception care, so preconception care and gender it involves, discuss some recent events and updates to the cervical screening guidelines, and also be aware of some of the common contraception methods in Australia. So we're starting off with preconception care, and these sessions, you know, we're hopefully got some medical students, we've got some JMOs, RMOs, GP regis and GP. So hopefully the GP regis and the Red Book and our RACGP guidelines for preventative activities in general practice. But I've put this in here to let our med students know that this book is a really good book to have a flick through. Definitely don't memorize all of it. You'll get bogged down in details, but it's really great. It outlines all of the preventative activities that we should be thinking about in general practice, and that's a lot. And that's one of the really great things about GP is that we see people from all different ages, and whenever somebody comes into us, whatever they're coming into us for, in the back of our mind, we should be thinking about what activities can we do for these people? What should we be thinking about? What preventative activities should we be thinking about? And why I think it's a really great place to start the talk today for preconception care is because it's actually the very first chapter of the Red Book. So thinking about preventative activities in general practice, essentially before life has even begun. So before you're thinking about getting pregnant or when you're thinking about getting pregnant. So every woman of reproductive age should be considered for preconception care, as we can see highlighted by the shaded age ranges that it has in the Red Book. Often it's something that we have to do in general practice as an opportunistic activity. So it's very rare, and I would argue it's only the very organised person that comes into general practice and presents for preconception care planning. It can be done as an activity for individuals, it can be done as couples, and the way that I view it is I think that it's something that as a GP we have to make people aware about, that it's something that they should think about. It's not necessarily something that people know that they should be thinking about it, like heart disease, for instance. And so, Jenny, can you play the video for me, please? So I'm just going to stop screen sharing. Oh, can you do that for me? Sorry, we're just...
Yep, just getting it ready now.
Well, thank you.
Can you see that?
I can't.
Okay. Oh, yes, sorry. Let me just go to... Can you see it now?
Yeah, now it's up.
No. Yep.
Yep.
Okay, the venue, the people, honeymoon.
Find someone to marry, find a dress.
Buy lots of suntan lotion.
Save some money.
Check the weather of where we were going.
The school holidays,
Where you will stay.
insurance.
I booked the flight. I booked the hotel. I don't really know. Oh my goodness. Gosh. I don't know.
Obviously, you have to have sex first.
I said to my husband, should we give it a go? He said okay, and we did.
I probably would think about, I mean, it's a more difficult thing to think about actually because we don't normally plan in that sort of way. Well, I didn't.
Thanks, Jenny. So a little video from Tommy's, which is an institution in the UK. So video started off, how do you plan for a wedding? You know, lots of women have great answers for that. How do you plan for a holiday? How do you plan for pregnancy? Less answers. So highlighting that women don't necessarily think about it or necessarily know what's involved, and that's where we can come in general practice. Sorry, I'll go through these again. So there's lots of different areas that are addressed by preconception care. Lots of areas like lifestyle factors, nutrition, alcohol, smoking, diet, exercise, some more medical factors. So thinking about medical history, have they been pregnant before, their mental health, their physical health, and then also social factors as well, where they're living, are they exposed to anything, domestic violence, you know, previous traumas. And preconception care consists of interventions that are aimed to modify all of those different factors that we saw in those previous tiles and different risk factors that women have, so we can increase their overall health and also impact on the outcome of the pregnancy. So we should include reproductive planning in this, and also the effective use of contraception to prevent unplanned pregnancy. So this is really interesting, I think, because we are addressing both sides of things. So preconception care also includes the prevention of pregnancy. So trying to plan for all pregnancies, and if pregnancy actually isn't the intended result, then making sure that we're providing effective contraception to prevent pregnancy as well. And we have evidence that preconception care prevents neural tube defects, decreases the risk of congenital abnormality, decreases the risk of an adverse pregnancy outcome, including miscarriage, stillbirth, and fetal abnormality. So some good research that's been done before showing that it's important and should be done. And we were talking a bit before about unplanned pregnancies. So I wanted in the chat box, if people could guess, in Australia, estimations of how many pregnancies in Australia are unplanned.
So we've got a couple of, so we've got lots, 70%, 50%, 60%, 80%. Be interesting to know, I don't know if you know the data on this, but how it's changed during COVID lockdown, because I feel it probably has changed a bit, but 50%, 80%, 65%, so a fair range there.
Yeah, so
all above 50. So.
Yeah, I like that everybody is very realistic and everybody is, I suppose, very accepting that it's quite common. But studies have shown it's about 50%, which is quite shocking if you think about it, that 1 in 2 pregnancies in Australia was unplanned. And so we're really losing this opportunity in the preconception time to really optimize all of these health goals and the health status of the woman as well before she gets pregnant.
There was an interesting comment here. So Gordo's mentioned that birth rates in his local hospital on the Central Coast have actually almost doubled in COVID, which is interesting. Yeah.
And I was listening to ABC Radio the other day, and they were speaking with a midwife saying that the baby boom during COVID has been large. Personally, just anecdotally, through patients and people I know, is that it's been, very busy in the hospitals when they've been delivering as well. So it shows that COVID, whilst it's been bad for a lot of things, has been good for the baby boom. So another question while we're writing in the chat box, this is for everyone, but maybe more targeted towards potentially our doctors already in the system, but who can type in the folic acid dose that we recommend for every woman, and also the dose that we have for an increased dose for women who are at higher risk. Something that our med students might know. But
Yeah. Okay, so we've so good range here. So yeah, so 0.5 milligrams for the average risk patient and 5 milligrams for the high risk patient. It's pretty consistent. And I think a good point someone's made here is that 400 or 0.4 milligrams, because I think some of the preparations come with that as well.
Yeah. So
yeah.
it's 0.4 or 0.5 normally. Fabulous. So moving on, when we're thinking about taking a history, so history for preconception care, starting with a reproductive life plan. So assisting our patients to have a think about what their reproductive life plan is. For some of them, maybe they've never thought about it before. Others will be very aware of what they, want to aim for in their life. The plan as well is whether or not they want to have children. So knowing that some people, that's not even on the radar for them. But if they do want to have children, discussing the number, spacing, and timing of intended children. So thinking very carefully about the interconception period as well. We know that there's studies that show the correct timing of children is also very important to women's health overall. And also we have to think about the spacing and timing, because if it's someone's goal to have 5 children, something that I don't think I have seen at all in clinical practice recently, but if they're 35 and want to have 5 children, that's going to be very different as well. So we also want to provide the effective contraception to enable the implementation of their reproductive life plan and reduce the risk of unplanned pregnancy. So we want to also, we've kind of highlighted with the 35-year-olds, discuss reduction in fertility with advancing maternal age as well. So making people aware that as they do get older, fertility is declining. A little bit of a decline after 30, but a steep decline after 35. So making people aware of that, because they're not necessarily. The reproductive history, asking if there's been any problems with previous pregnancies, such as infant loss and birth defects, particularly neural tube defects. Wanting to know about low birth weight, preterm birth, gestational diabetes, just things that we want to, I suppose, have our radar up about. Also, if there's ongoing risks that could lead to a recurrence of any of those things in future pregnancies. In the medical history, asking if there's any medical conditions that can affect pregnancies, so thinking about their thyroid disease, hypertension, epilepsy, thrombophilia. Are they on any medications for those conditions as well that could potentially affect a pregnancy? Could they be teratogenic? And also we want to consider if their current management for those conditions is ideal, because we know that embryogenesis obviously occurs early on, and we want to make sure that we're getting in there before the patient has become pregnant, so we can actually make some changes. For diabetes, I'll just use an example. We know that the HbA1c at the time of conception is what matters. So it doesn't matter in the studies if, obviously it matters, but in the studies it doesn't matter that a woman, for instance, maybe has an HbA1c of 12. Throughout her pregnancy, there's amazing dietary and exercise interventions. She's so well, and then when she delivers, her HbA1c is 6.5. It actually, the risk factor for the baby is the HbA1c that she had at time of conception. So it really shows that we have to get in there early, and when we can, obviously it can be hard, but try to get in there early and help bring down some of those risk factors. So we also want to ask about the genetic and the family history. So has there been increased frequency of intellectual disabilities within the family, multiple pregnancy losses, stillbirth, early death, children with congenital abnormalities? So any of these risk factors, we're thinking about the presence of a genetically determined disease. Patients of particular ethnic backgrounds might be at increased risk as well. So they might benefit from genetic testing and genetic counselling. So we're thinking about possible consanguinity. So for the med students, we're thinking about the patients, the patient and their partner, are they related to each other by any way apart from marriage can be a way to ask. So are they cousins? Are they second cousins? Are they some kind of relation apart from being husband and wife? We should, as GPs, think about referral to genetic testing because it often takes a lot of time and can be quite complex. So we need to think about, okay, does this couple need a referral for some reason? And if so, it might be worthwhile doing it early. And also leading into this genetic kind of subcategory is that now we have genetic carrier screening available as well. So it's RACGP's standpoint that it's of their opinion to offer carrier screening to everybody and just making them aware that it's available. So the most common tests that are available on the market look at 3 genes: cystic fibrosis, Fragile X, and SMA. So often cost the patient a number of hundreds of dollars out of pocket. So that's why I personally find it hard to offer it to some patients because it's out of their price point, but knowing that RANZCOG and RACGP say that we should offer it to and make people aware that it's available. And also substance use, so asking about smoking, alcohol, other drugs, and using our referral pathways when we need to as well. So coming over to physical assessment, so breast examination and cervical screening if it's due, also BMI, so we know where we're starting and know where during pregnancy our weight goals might be falling, and also doing a blood pressure check and checking the oral cavity as well. So we want to have a dental checkup as well, ideally within the year of becoming pregnant. We know that poor dentition and a high level of dental caries can actually affect the fetus. Unsure about details surrounding that, but potentially the biodome and how that interplays. But a high burden of dental, I'm thinking like adverse dental plaques and things like that can actually be related to preterm birth as well, and poor dentition in the child. So just keeping that in the back of our mind. Vaccination, so something that's really we're very familiar with, so particularly MMR, hepatitis B and varicella. So being aware of these, screening to see if a patient has previous protection against it and with their serology, and if not, offering these vaccines before they become pregnant to allow for sufficient protection. So with MMR and varicella, we know they're live vaccines, and therefore giving them to a patient and advising that they should wait 28 days before they try to become pregnant. Interestingly, there's a new vaccine, I think that's just become approved by the TGA sometime this year, maybe around June, but Shingrix, which is a new varicella zoster vaccine, and it's not a live vaccine, so it can potentially be available for pregnant women, but it hasn't been studied very well in pregnant women, which is not surprising. but just being aware that there is potentially a vaccine available in the future that we might be able to give pregnant women for varicella if needed. So we're also thinking about vaccinations when women become pregnant as well. So thinking about the flu shot and the DTaP as well. We talked about folic acid supplementation already. So knowing that our normal dose is 0.4 to 0.5 milligrams per day. And for high-risk patients, we're thinking about 5 milligrams per day. And high-risk patients, we're thinking about patients who might be taking anticonvulsant medicine, those with pre-pregnancy diabetes, previous family history or personal history of having a child with a neural tube defect, and also women who have a BMI greater than 30. So I think that category is often forgotten about, excuse me, because quite a lot of women that we see might fall into that obese category, and they need a higher dose. And the final category of women that need the 5 milligram dose is those with malabsorption, so people like celiac disease. Also thinking about iodine supplementation, so 150 micrograms per day. And talking to women about, their options for having those supplements. So one that I like to recommend is the iFolate by Blackmores. It's a very small tablet. The price point is quite favourable as well. And it's because it's small, it doesn't have iron and, other minerals and supplements. It's quite good for women who feel nausea. There's your Blackmores, bigger pregnancy tablets, and Elevit and, other brands. They can often be quite big tablets, cause nausea, and be quite expensive as well. So obviously targeting the supplements to women who might need them, but also knowing that we want, it's not necessarily necessary to take those supplements as well. Sorry, Chris.
I was just going to say, so George has asked a good question, which might be coming to the group. So what blood tests would everyone consider for preconception bloods? And so I guess there's a standard list that we all do. So I don't know if everyone wants to just quickly write that in the chat. In terms of the best timing for this, because I'm listening to this and thinking, yeah, this would be awesome to be able to do for all my patients. But what do you think the best timing is? Because I guess most of the time it's opportunistic unless someone's really organised and comes to talk to you about it. How do you manage that in practice, Jess?
I've got a slide coming up.
Okay, cool. That's good. So I think everyone must be ordering a lot of blood tests because I haven't got any chat coming up yet.
Yeah, and it is a lot of blood tests as well. It is quite the panel.
And I guess you can set up, I guess, for the registrars and JMOs, if they're coming into general practice, you can set up favourites in most of the like best practice or medical directed practice software. Obviously, you always want to tailor your investigations to the patient and use rational test ordering, but it can be helpful to have a favourites list, so you can just go click preconception care bloods. Right. Well, while everyone's typing that up, I'll let you keep going, Jess. So, here we go. I've got some now. So rubella, varicella, TSH. TSH is interesting. I wouldn't mind if you comment on that one, Jess, because that's over the years that's been. It depends on who you talk to. If you talk to some obstetricians, they're like, you must do a thyroid, and then you talk to other obstetricians, they're like, no, only if they've got risk factors. What's your thoughts on that?
So what I heard, teaching that I understand, is that you should do TSH preconception, but then during pregnancy, it's not needed, early stages of pregnancy. So definitely in preconception bloods, yes, but antenatal bloods, no.
Okay.
Which to me doesn't necessarily make much logical sense, because if you've missed that preconception window, surely maybe there's a bit of a benefit to come in that early antenatal period. But yeah, that was the teaching of it.
Yep, cool. I think just a tip for young players as well, just a reminder that the TSH levels, the normal range changes in pregnancy, and I believe it, and don't hold me to this, but something to do with the beta HCG. But there's ranges depending on the stage of pregnancy, and Health Pathways has a nice section on that actually around that. So just be aware that if you see a low TSH in pregnancy, make sure the labs actually was aware that the patient was pregnant before you rush them off to an endocrinologist.
Yeah, which is a really great lead in as well to writing really beautiful descriptors on our pathology forms when we order as well, and making sure we give the pathologist as much detail as we can. So we've talked a lot about, you know, all of these things to consider, and we haven't even talked about men. So we think keeping in our mind as well that to have a baby, we need an egg and sperm. There's a 3-month life cycle of sperm production as well. So thinking about changes we can make to men and knowing that there's this lag time. So whether that's healthy eating, exercise, stopping drugs, you know, cutting down on alcohol. And I've put age in there because we know that sperm production does decrease over age and, you know, quantity, quality, but also men don't really have the severe fertility drop off like women do as well. So this leads into what Chris brought up about how I bring up preconception care. So this leads into some of the research that I did in 2019 with Kirsten Black's group at the University of Sydney. And it was about how to bring up preconception care in general practice, because it is something that's quite challenging. We know there are well-documented barriers, just time being one of it. But the Oregon Foundation for Reproductive Health from America has come up with this tool called One Key Question, and it encourages health practitioners to routinely ask women of reproductive age, would you like to become pregnant in the next year? And then the clinician can document one of 4 patient responses. So yes, I'm okay either way, unsure, or no. And depending on this answer, the clinician can then follow up with information around preconception care or contraceptive methods and kind of funnel them into the appropriate pathway. So the research that I did was testing this question in Australian general practice, and it was really well received by patients. It was well received by general practitioners as well. But one of the findings from the qualitative arm of the study was that GPs like to frame the question. So GPs found it a bit stark to, in, you know, a consultation where someone's coming about a sore toe, be like, okay, you're, you know, a 25-year-old woman, would you like to become pregnant in the next year? So framing it with some question like, you know, I ask all women of your age, or ask people of your age just what they're thinking to do about their pregnancy, using things like cervical screening, or, you know, other women's health related topics to kind of feed into their question, but some kind of frame to link things in. And we found that women really liked being asked about it, didn't mind talking about their preferences. And so, yeah, just, I suppose this is one way we can think about how to bring it up in general practice. And one more tool is Your Fertility, which is an NGO running out of Melbourne. And they have, if you just search Your Fertility and Healthy Conception tool, they have tools that you can either give the website to your patients and they can work through, or you can work through it together. But you can select different factors. So I've just put in things about an average patient, lifestyle factors, and then more specific questions as well. And so you can work through and answer those. And then at the end, press submit, and it comes up with some health related information. So it already gives you a bit of an indication whether it's good or maybe it needs something to be thought about, but then gives you a bit more follow-up information, and patients can bring that into you as well, and you can talk about things.
So there's some comments about for men's fertility, just going on a couple of slides about not wearing tight underwear or jeans, and Gordo's wondered how we discuss with some of our patients. One question I had around that, there's a lot of products in the market for thinking about men's. We obviously folate is well researched and important for our women, but for men, is there any evidence for the prenatal virus? So there's a couple of different brands out there to boost their fertility, and Amenavid and other names out there. So what are your thoughts about that for men?
I haven't seen any research that supports it. I know that Menavit does quote I think they quote research saying that it's beneficial, but I haven't actually read the paper, so I can't. My feeling is that, normally healthy eating and healthy lifestyle can, replace the need for supplements just in a lot of things. But no, I haven't read any of the data, so I'm not sure.
Cool.
But yeah.
I think that's my understanding as well. And like Gordo said, there's lots of advertisements for Menavit out there, but I just wonder about the validity of it. But, cool. So just a 24-minute warning for the rest of the talk.
Thank you. So we'll move on to cervical screening. And the reason that I picked cervical screening is because there's been updates to the cervical screening pathway. So I thought we could just focus on that. For our med students in the audience, just a bit of background, that cervical screening used to be known as pap smears, and I'm sure our GPs are very aware of this and very familiar with the older system, but it used to be every 2 years, starting at 18 years old or 2 years after the first sexual intercourse, whatever's later, and it was a cytology test. So get cells from the cervix and someone would have to look at them under the microscope. And now I've moved to cervical screening, where the process of collecting those cells is the same, but instead of smearing it on a glass slide in the pap smear, we're putting it in some liquid for some liquid-based cytology. And sorry, I should say we're doing an HPV test on it first, and if there's any flag for oncogenic types of HPV, then we go on to the liquid-based cytology. But just our stock standard test is just doing the HPV test on it. So it's moved to every 5 years now because we know that it's more accurate. So instead of looking for those changes with the cytology, we're looking for HPV, the virus that is causing those changes. And it's starting at age 25 instead, and you have an exit test 70 to 74. So we're looking at the external genitalia using a speculum to visualize the cervix, and then taking a sample of cells from the transformation zone. So I've just put in some pictures. So we this week have med students who are starting placement, and hopefully you become very familiar with all of these different tools and get to see a cervical screening test, and potentially even get to do one yourself. But we have a speculum. In general practice, a lot of us would be using plastic speculums now. I know that I do. They just don't photograph as well, which is why I put the metal one in. We have our different brushes as well, depending on a woman's age, depending on her cervix, and also some liquid-based media for putting the cells in. So we have our cervical screening pathway, and just wanting to focus on the middle section because that is what's changed. So if we have no HPV detected, then we just have, it's in the green. Sorry, I don't think you can see my cursor. It's in the green. So routine screening every 5 years. If we have one of the high risk oncogenic strains, so 16 or 18, we go straight, we have, first of all, the liquid-based cytology, so looking at the cells, and then regardless of what we see in the cells, referring for a colposcopy assessment, so referring to our gynae colleagues for the med students, that's what that means. And then in the middle is where things have changed. So it used to be that if we found we had HPV non-16, 18 detected, we would then go on to do a repeat test in 12 months. And that is what happens. Sorry, I should say that if it's a high risk result on the liquid-based cytology, we refer for colposcopy. But if it was in this kind of more uncertain area, so just a normal liquid-based cytology or possible low-grade change or a low-grade change, then we would then go on to a repeat HPV test in 12 months. So we still do that. So at the repeat, if HPV is not detected, then that person can go back to normal 5-yearly screening. If a high risk HPV is detected, so 16 or 18, then we refer to gynae like normal. But the changes have come if once again at the second 12-monthly cervical screening, the HPV test, if we find not 16, 18 again. And so if it was found that 16 and 18 again, what we used to do, so pre-December last year, is that we used to refer to gynae for COLP assessment. But here we have a look at what the liquid-based cytology is, and if it's normal or negative, possible low grade or low grade again, then we do another repeat test in 12 months' time. If HPV is not detected then at 12 months' time, so that's 24 months or 2 years since the very first test, then we go back to routine screening. But then if any HPV is detected, then we refer to colposcopy assessment. So that's essentially what was happening before, but we've just added another step in. So I'm just zooming in on that area because I know describing it in words isn't as straightforward, isn't as clear, can get a bit jumbled. So we're coming in where this is the first follow-up HPV test. So knowing that at this first follow-up HPV test, if we have a negative HPV not detected test, then that's fine, discharge to 5-yearly screening. If they have a high grade 16, 18 HPV, then we refer to gynae. But then at this first year follow-up, if HPV not 16, 18 is detected once again, and then we have normal or negative or a possible low-grade change or a low-grade change, then we're repeating in 12 months' time. At that 12-month follow-up, so 24 months since the first test, if HPV is not detected, routine screening. If HPV of any type is detected, then we go to colposcopy. So just adding in an extra step there. You can see in the grey box that there's a group of women that this doesn't refer to. So women over 50, Aboriginal and Torres Strait Islander women, and women who are overdue screening by at least 2 years. This doesn't refer to them because we know that all of those factors make them at higher risk that they could have an underlying pathology. It's also different for women who are immunodeficient. So we know that they need a colposcopy referral for any oncogenic HPV because we're worried about their body's ability to clear the HPV virus. They're more likely to have cervical changes. Women who are aged, I don't know why that's had a bleep, but that's more than 70, it should be, attending for an exit cervical screening. So they need a colposcopy referral because we want to make sure that we're very confident that they don't have any cervical changes before we discharge them forever. Women who are exposed to DES in utero because they have a higher risk of cervical and vaginal clear cell abnormalities, and also women who are undergoing a test of cure because there are specific guidelines for that as well.
So I've got just one point here. So Georgia was saying that she had a recent patient that had HPV not 16, 18, then a possible low-grade lesion on cytology, but she was over 50, but the lab has recommended repeat HPV at 12 months. So it sounds like that's you exit the pathway now because of age 15 go straight to colposcopy. Is that right?
So was this her first test, Georgia?
Was it her first HPV test?
Yeah.
No, it wasn't. She was actually, I think it was 3 years since her previous one, but she'd had some abnormal bleeding. So I did a pap smear, but worked out it was superficial bleeding from vaginal atrophy, from vulval atrophy. So I found the source of the bleeding, but the cervical screening test came up as HPV, non-16, 18, possible low-grade lesion, repeat 12 months. But according to your little diagram, it says they're over 50, they should be referred to for colposcopy. So I was interested to read that.
So I suppose this is her first screening for this time. So it's still falling in the first part of the top half of the flow diagram.
Yeah, so she's had a HPV test before, but that was 3 years ago, which was normal.
Yeah.
So this, yep.
Time, repeat in 12 months.
Yep.
And then the box for women over 50 falls in for their if in 12 months time it still has those changes, that's when that comes in for her.
Great, thanks for clarifying.
Incredibly confusing.
It is.
I wish we could just go back to the previous screening. It was so much more straightforward. Kristen's made a really good point here. Is it safe to rely on the pathology report recommendations on this result where the patient's screening history is unclear? Do we know if they tap into the CST register? I think it's a really good point because I don't do enough pap smears clearly, and so I always check this flow chart because it's not clear in my head as a male GP. But I'd be interested to know. You obviously do more pap smears than me. Do you rely on the pathology reports, or do you always check your patient history?
Good question. I suppose I have it in my head, so I know whether it makes sense or not, and they are pretty good in my experience.
Okay.
So I find them quite reliable and on top of things, but I guess my gut instinct is no, you should never rely on them because it falls back to you. But in my experience, they're pretty good.
Okay. Excellent. And then just if we just quick divert back to the previous topic, there was just a question here about iodine supplements and preconception care and just whether healthy eating can do the job. I know when I started off in GP, it was basically just add a bit of iodized salt to their diet, which I guess we probably won't want to add too much salt to pregnant ladies' diet. But what are your thoughts around that? I guess we're not really in a iodine deficient sort of country, but what are your thoughts about that?
I think we just don't know what people are actually eating and taking, and is it adequate? And once again, probably my gut feeling is a lot of our patients are iodine replete, and their diet involves foods that would include enough of iodine to be adequate for their supplementation. But I suppose not enough is known, and we know that iodine is really important. So taking the iodine tablet is the best way to go.
Mm-hmm. And obviously, and I think, I can't remember if you mentioned it, but Elevit comes with iodine now, doesn't it? And some of the other ones, so it's
So all pregnancy breastfeeding vitamins will have the correct dose of iodine in them.
Oh, cool.
So just reminding us that cervical screening is a screening test, so different investigations for symptomatic patients as well, and self-collected swabs are possible. So self-collected swabs for women who are over 30 years of age and have never had a cervical screening test before, or who are overdue by at least 2 years. And so allowing them to do a self-collected HPV vaginal sample is helping target these women who are underscreened. And we know that most cervical cancers are found in this population. So I've just included this from the National Cervical Screening Program website, but just being aware that it's available and it's something that we can provide to our underscreened patients as well to help encourage them to participate in some kind of screening. So I thought we could do a little mini quiz. I'm just looking at the time and we just have a little bit on contraception to go. So maybe if we just pick out some cervixes and talk about what they are. But does anybody want to type in the chat box what B is?
I think we're some great answers here already. On the ball, everyone here. So ectropion.
Perfect. And let's pick one more. Let's pick F.
This one definitely tricked me as a registrar. I was very worried about a patient I sent to the gynecologist with this. Yep, so we've got some Nabothian cysts for the those yellow sort of lumps there that we can see. So
Perfect.
Yep.
So we've got a huge range of cervixes here. So for our med students, hopefully you can become well aware of what's normal. So A and C are nulliparous and a multiparous cervix, which are normal. And then, you know, obviously looking at normal, we become more attuned to what might be abnormal. And we're just going to finish a little bit on contraception. And I just had to include this because I thought it was funny that Crocs are 100% effective birth control, because Crocs are now making a comeback as well in fashion. So I just couldn't help but put that in. But just having to think about if we were to develop the perfect contraception, if you could type in the chat box, what things would we want this perfect contraception to be?
So side effect free, highly effective, set and forget, easy to use, highly effective.
Perfect.
Oh, and there's a good article link here Amita's put in for us on iodine in Australian pregnancy, which is great. So we'll have thanks Amita, we'll have a look at that. So 100% effective, no room for human error. That's right, easily reversible, no side effects. Again, focus on cost, another important factor. And yeah, 100% safe, reliable, and 100% happy patients would be good. Oh, and men to use. Yeah, that's fair enough.
That's right. I love that, Anita. Yeah, definitely. More work needs to be done there. But yeah, you've definitely hit all of the big areas there. And, you know, we'd love these 100% effective, 100% safe. And we know that we're definitely working outside of those 100% numbers. But when we're thinking about these different areas, thinking about how one size doesn't fit all for all of our patients, you know, thinking about potentially their reproductive stage of life, cost, discretion, how easy it is to use. So it can be very patient specific as well. And, you know, we have lots of different options for us. So this is from Family Planning Alliance. But in Australia, we know that we're a country that loves oral contraceptives, so loves pills, and we love condoms. And this is from the Australasian Study of Health and Relationships. So I thought that we could talk a little bit about the pill, and just a reminder of missed pill rules, because I think that that's one of the sometimes the most complicated thing to be talking about with our patients. So missed pill rules, so we define a missed pill being more than 24 hours late. So that means that we took our pill on Monday, we completely forgot it on Tuesday, and then it comes to Wednesday when we normally take it, and we realize that we haven't taken one since Monday. So pills that are less than 24 hours late, so that means that there is no more than 48 hours since you took your last pill. You can just take your pill as soon as you remember, and then you take your next one at the usual time. So that might mean that you're taking two pills on the same day, and that's okay. You're still protected against pregnancy. But for missed pill rules, we're thinking about more than 48 hours since you took your last pill. So you take it as soon as you remember, and you might be taking 2 pills on the same day. Throw away any missed pills, and then telling our patients that it's important that they need to abstain from sex or use another form of contraception for the next 7 days. The dangerous part is in the first 7 pills after the inactive sugar pills, or the placebo pills, or whatever we want to call them. And if they've had unprotected sex in the previous 5 days, then they're vulnerable. So we just have to think about emergency contraception in that instance. In that last week that's leading into the sugar pills, if there's a missed pill within that time period, then we skip all the sugar pills and just go back into the active pills. So moving into emergency contraception, I thought it could be good to talk about as well. So knowing that there's 2 different types of emergency contraception that's available. So there's a single dose of levonorgestrel. People can get it over the counter, but I know that I prescribe it a lot as well. So my patients come in to see me. And it can be taken for up to 72 hours after unprotected intercourse. And the reason I thought it could be good to talk about emergency contraception is because I know that some people aren't aware of Ellaone. So there's another option as well for emergency contraception, and this is a ulipristal acetate. And it has been shown that it is more effective at all the different time points when compared to levonorgestrel. And so it's more effective at 24 hours, 72 hours, and 120 hours. And it has been licensed to use up to 5 days as well. So Ellaone's more expensive, and also it's a bit more complicated when we're restarting hormonal contraception. So we can't just restart the pill, for instance, straight away. We have to wait 5 days. But just being aware that that's available, and it can't be used in breastfeeding women as well. And mentioning as well that we have the copper IUD as emergency contraception to use as well. And just the last slide, we're not going to play these YouTubes, but just to make you aware, particularly for our med students, that Googling Implanon insertions and IUD insertions can be really interesting before you go on placement, and hopefully you can see one on placement. But long-acting reversible contraceptions are really good, effective methods for contraceptions to offer to our patients. They're more likely to have an unintended pregnancy, which is good. And at the beginning of 2020, the Kyleena was introduced as well. So it's a slightly lower amount of levonorgestrel compared to the Mirena. Still lasts 5 years. It's 99.7% effective versus 99.9% effective. And it doesn't have as much control over bleeding, like stopping periods, like the Mirena does, but some women prefer that. And that's the end. If there's any questions.
I think I'd really reinforce as well just that whenever we're doing script appointments, that it's never just a script appointment. You know, if someone's coming for a contraceptive script, we never assume, and this is more for the young players, that someone has asked about contraindications. A number of times I've done just a pill script appointment, and someone has migraine of aura, or they have hypertension and smoking, or they have something else going on, and they're actually not suitable for the combined oral contraceptive pill. So treat every patient as a new patient, unless they're your patient. You've already done that conversation. And I think also every opportunity. Every time you do the script, it's an opportunity to revisit that information just gave about missed pills. It's amazing how many people don't know the rules around if you miss a pill at the start of the pack versus the end of the pack, and tricycling packets. And I did a script yesterday for a lady who'd been off it for 3 weeks and was not using any form of protection. And so I had this whole conversation about, so you planning to get pregnant? No. Okay, well, we're going to have to restart it at this. But, so there's a whole conversation about when to restart it and so forth. So very important. I've put in a link as well, just for the family planning handbooks. If I'm sure most of you have seen them, but they are gold, especially for the registrars and medical students. This is your study in one resource. So the contraceptive handbook has everything in it. You want to have it under your desk in the office. And the family plan, so the reproductive and sexual health one is now online, so you can have it on your phone. And it covers everything, fertility to pap smears to breast lumps, everything. So really great resources. They do a course, a certificate course, which is excellent, by either face-to-face or distance. So again, particularly for the male GPs out there, I did it when I was a registrar because it was a focus. It was an area that I felt was a gap, and it was excellent to cover that. And I think that there was Gordo's made an interesting point. So Ellaone $30 is twice as expensive as levonorgestrel $15, according to the Chemist Warehouse website. Yeah, okay. Now, so George's. So I don't think there's any other questions so far, and we've hit time. But George's had a question here. Are there any practice or GPs or registrars interested in running one of these sessions in the next month or so? We'd love to see you here. So yeah, you can either email Marguerite or Georgia. So the idea being that you take a topic and present it over the 45-minute to an hour session. And so I'll be doing next week with a bit of a focus on clinical reasoning and case-based discussion. So yeah, be very keen to get everyone involved from the different practices and different levels as well. So excellent. So any final questions from anyone, or? Look like it. So thank you very much, Jess, for giving us that overview of women's health this morning. I've definitely learned some extra things, which is great.
Thanks everybody for coming, and thanks everyone for typing in the chat.
Yes.
Thanks everybody for coming today, and Jessica, thank you so much for that, and Chris, thanks for facilitating the questions. The next session is on the 22nd of September, so 2 weeks from today. Thanks everyone.
Well done, Jessica. That was all good. It's always something new to learn, isn't there?
Yeah, so much. Yeah.
There we go. Okay. I was just waiting for everyone to head off.
Yeah, I know, it was an uncomfortable start.
I know, yes. Okay. So it's okay, we finished.
Yeah, we're still recording as well, but that's
cool.
fine. Yes. Very good. So I think,
Actually, can we stop Jenny, can we stop recording? Is that if we can?
Yeah, I don't think we can do it from here.
Okay.
Left.
Oh yeah, no, I don't have access to stop recording. Cool.
So I think it's Jenny. That's all good.
That's cool.
Okay.
Awesome. Yeah, no, it's a good overview. It's
Yeah.
I think and some good discussion and stuff, which is great. So
Yeah, good. It's always good.
excellent. And we can debrief at the next meeting anyway.
Yeah, beautiful.
Okay.
All good. And hopefully we'll have some volunteers for the next few.
Yeah, exactly. Yeah.
Because I thought I'd do a little plug while everyone's there, and
Yeah.
actually,
Yep.
rather than relying on them reading about on the email. So
Yep.
yeah,
No, excellent.
excellent.
Fantastic.
Thanks,
Okay.
everyone.
Awesome.
We'll
All right.
chat next week then.
That's
Get back
good.
to work.
Okay. Yeah. Have a good day, guys.
Yeah, great. See ya. Bye bye.
Bye.